Today we're just going to go through the airway assessment and patient positioning skill sheet. First of all, we've got our patient here. Patient's going to be Aaron today. We're going to go through our indications before we do any sort of airway assessment. So the indications are preparation for intubation or any other airway management. We've got the situation of can't oxygenate, can't ventilate, so looking at surgical. We've got potential for airway or patient deterioration. We've got identify for a difficult airway, so sort of high level Malapati scores. We've got improved ventilation and potential improvement for shortness of breath symptoms, and safe facilitation for procedural management further down the line. Next we're going to go through our procedure and or method. So in preparation we just want to make sure we've got 360-degree access around patients. So around Aaron we've got our sort of dummy in the way, but mostly 360-degree access. We need to make sure we've got everyone in the room on board with the plan with the patient, so any airway assessment, any sort of skills that we need to perform, we need to make sure everyone's on board and everyone's aware, so communication. And we also need to make sure all equipment is set up, which we'll go through in further skills assessments. So in initial stages of the airway assessment, we've got airway emergencies. So obviously in emergencies we've got things like potential airway obstructions that we need to be wary of. With any sort of obstruction we've got things like stridals that we can listen for. We've got hypersalivation, especially in children. We've got high secretions, snoring, and or any other sort of trauma. So that's when you're looking at MVAs, falls, anything else going on. Complete obstruction, we can sort of have a look at through evidence of silent chest with auscultation of the chest, no rise and fall or unequal rise and fall, or respiratory arrest. So we can have no respiratory effort at all. Next we're just going to have a quick look at inspection and note of the patient's sort of face. So first we're going to note if he's got any sort of beards, facial hair, anything in the way. Aaron's still in puberty, so hasn't actually grown any hair as of yet. So don't have to worry about any amazing looking moustaches or beards. We need to make sure we haven't got any sort of overbites or underbites. Aaron's got quite a large chin jaw as well. So we need to make sure the patient's got the ability to speak. So just want to say a few words for us.
Anytime.
Oh, perfect, there we go. So the patient can speak, and we need to make sure he hasn't got any sort of previous surgeries, or any sort of major dentures or any sort of anything like that. So for any sort of procedure that we're going to do any airway assessments, we need to make sure we take dentures out to make sure there's nothing loose in the mouth. That obviously gives you a lot more room, gives you a better grade view as well. So if we'll go through the conscious patient first, which Aaron's going to be. First we're going to work out a Malapati score. So we're going to see if we can get Aaron to open his mouth as wide as possible, which is, wow. We've got a grade 1 view, which is fantastic, which is as good as you can get. What we're going to do is, we're obviously going to protrude his tongue, open his mouth as wide as possible, and see if he can actually stick 3 fingers in his mouth, which even his fingers he still can, which is great. We're going to next have a look at the range of movement, so the flexion and movements from left to right. So we've got a nice 45-degree angle and head up and down. Before we do any of this in a either conscious or unconscious patient, we need to make sure we've got any sort of cervical spinal precautions in place. If we do, then we're going to have a modified view. We're going to make sure that he can actually expel air through both his nostrils and his mouth, which he does. So there's no sort of air obstructions or deviated nasal septum or anything like that going on. So what we're going to do is we're going to quickly just go through the Lemon Malapati score assessments. So we're just going to have a quick look. So we're going to open his mouth, put his tongue out. Cool, so I've got a good view all the way down. We're going to evaluate the 3-finger rule, so he's already put 3 fingers in his own mouth, which is great. I'm then going to put my 3 fingers underneath, which we've got nice movement of, and he's got 2 between there and his throat. Beautiful. We're then going to make sure he hasn't got any sort of obstructions, and we know there's got clear nasal passages and breathing, so there's no obstructions that we're worried about. Aaron isn't quite on the obesity scale, but we're keeping him fit and healthy. So we don't have to worry about that either. And neck mobility, we've already been through his rotational and flexion. Next we're going to do the auscultation of the chest. So if we're at a stethoscope, we're going to go front, back to make sure we have good listen. SpO2 monitoring via monitor, which will provide us a baseline. Then we're going to get an airway checklist if we're going to go through ET intubation or any surgical airway maneuvers or SGA insertion. Next we're going to look at patient positioning. So that's for the conscious patient. For the unconscious patient, we're going to move to the mannequin down here. With the unconscious patient, obviously we're going to do a modified Malapati score, so we can't actually get the patient to open their own mouth. So what we're going to do is we're going to sort of use a jaw thrust or a chin lift to have a look at sort of the airway in terms of what we can see down, what sort of structures we're looking at, make sure they haven't got anything loose. This guy's got obviously fake teeth, but we're going to leave them in situ. And then we're going to do the 3-3-2 rule as well. So we've done our limit assessment. If we need anything in terms of manipulating the patient into a better position, what we can do is we can use a ramping technique, which is basically getting the patient to lean forward. We've put our handy-made towel here, and we're going to be looking for the three-axis alignment, which is, if I can get my hand to find my three-axis alignment. Excellent up. Beautiful. So we're going to look for the laryngeal, pharyngeal, and the mouth alignment, which is here, here, and here. Also, you can go ear to sternum, which is another good alignment technique. So we can use either pillows, blankets, kits, whatever you like to get that view. Beautiful. We're going to pay attention to, especially in the elderly, any sort of kyphosis or any sort of neck issues at all. While doing any sort of manipulation of the upper airway, we need to watch for any cervical spinal movements, especially if there's trauma, MBAs, or anything else involved. We'll do a modified sort of head and neck manoeuvring to be able to have a safe approach to the patient. For any sort of considerations in any sort of airway assessment, either the conscious with Aaron or the unconscious with our mannequin, we need to have an early assessment, and sort of prior preparation is key. We need to make sure everyone in the room's got the same idea and got the same plan of what's going to happen. In complete airway obstructions, we've got to have a plan. So what we'd be doing is not only just doing a Mallampati score, but we'd be looking at our second, third, and fourth option down the line. So looking for surgical crikes, getting early positioning of where our next procedure is going to be. Communication is paramount. Obviously, I've touched on it a couple of times, and having our fallback plans. If our airway assessment proves to be difficult, we need to make sure that we let everyone in the room know that their plan is going to be difficult, and to have our backup plans in place. And that's the airway and patient assessment skill sheet.